Welcome to our first episode of Commitment to the Conversation. This is the official launch of our year-long campaign, Commit to Health Equity. I am Natalia Gray, your moderator and part of the commercial organization at Onduo. As a multi-ethnic woman in healthcare, I have a personal vested interest and passion in this topic. And one of the largest trends in the employer benefits and healthcare delivery spaces I hear is our employees and our members really want to receive care from a doctor, provider, or coach who looks or identifies similar to them. We're so excited to have members of our Alphabet family here to discuss social determinants of health and why this data is important to us to help us understand how to use digital health interventions like Onduo to personalize care. Joining us for this discussion, we have Dr. Erich Huang, Chief Science and Innovation Officer at Onduo, Dr. Alex Macalalad, Senior Data Scientist and Biostatistics Lead at Verily, and Dr. Vindell Washington, Chief Executive Officer at Onduo. Vindell, let's set the stage and kick it off with the first question. Why do you think it's so important to have these conversations about social determinants of health?
Thanks, Natalia. Thanks for the time. I would say when I think about social determinants, and to be really direct, we're talking about really those social and environmental factors. You saw a few of them flash up in the pre-meeting. They have an oversized effect on the health status of any individual group. And so I practiced medicine for 25 years. I was very proud of the direct healthcare engine that I was a part of and the care that I provided. But the fact of the matter is that when you talk about the health status of a community or even the health status of any one individual, that direct care really is a small component of their health status. And so if you think about the activity itself, you have maybe, if you have a chronic disease, 3 or 4 visits a year with a provider. You spend maybe 8 or 10 minutes in that office with direct contact with the physician that's in place there, the physician assistant or nurse practitioner. But that's a tiny amount of the time that you deal with your disease. And so we think about at Onduo this opportunity to use digital tools to expand upon that connection and time that we have with any individual, and to think about it in terms of what we can do with the data sources, et cetera, to personalize that approach. That's to say, not every single individual needs the exact same thing at the exact same time, just because they share, for example, a chronic disease state. And so understanding what happens outside the office, understanding what happens in any individual's life, we think is paramount and really improving the health of the communities we're trying to serve.
Thank you, Vindell. Looking at that slide up here and seeing that direct healthcare only drives 10% of outcomes, and as we see that shift from brick and mortar to digital healthcare, it's so important about how we innovate and move forward. And shifting over to you, Alex, how are you feeling on thinking about social determinants of health from a measurement standpoint?
Sure, Natalia, thanks so much. The first thing I think about are what are the social determinants of health? I mean, typically when you think about SDOH, you're thinking like social economic status or race, ethnicity, gender. But there are other frameworks, such as from the National Academy of Medicine, that also include like social relationships, how isolated you are, or what your residential or community context is. Do you live in a rural area, or do you have access to safe, affordable housing? Do you have convenient places to walk? Do you have access to nutritious quality food, or access to pharmacy or clinics or hospitals, or even mental health? So under this framework, we can assess the needs for equitable healthcare. So do people have access to medication, food, transportation? Do they have parks and community spaces available to them? Do they experience discrimination, or do they have economic stability, housing stability? Are they safe where they live? We can measure some of these needs at the community level where people live, using like US Census data and community level data that are publicly available. And you can get them at the county level, at the zip code level, down to the census tract level. One thing that's clear, though, across all different communities, digital health and telehealth can break down barriers by making healthcare more accessible and convenient. 87% of people have smartphones, so it really makes it easy for telehealth to remove barriers due to time or distance. And this is something that we've all experienced firsthand in the COVID era. Even when people didn't feel safe enough to venture outside of their front door, many could still access healthcare through their smartphone. So I think that's really important.
And to piggyback, reducing barriers and increasing access to care is definitely top of mind here at Onduo. Erich, how do you think this applies to Onduo specifically from the program?
Well, a lot of the things that Alex just talked about are really important, in that now there's sort of a structure of metrics that we can collect around social determinants, and there's been existing sort of US Census activities to actually identify and standardize those metrics. And one thing that's important, though, is having metrics in and of themselves is great, but you've got to do something with it. And I think that's a key for digital health options like Onduo, is that you want to actually incorporate those metrics into what you do, so that you can actually have some, useful impact on those metrics. And I think one of the keys then is to go back to a point that Vindell made, in that traditional healthcare has relatively sparse interactions with their patients. Yet health happens at home. Health happens to people every day. The smartphone technology that Alex was just talking about gives us the possibility of having access to people on a daily basis, which, for me, who came from a conventional health system, I didn't have. So that's really important. So that gives us the opportunity to be there. It gives us the opportunity to start actually collecting those metrics and start acting on them, because health is very multidimensional. And we talk about the conventional dimensions of laboratory values, diagnosis of specific conditions. Those are really important, and obviously that's a big reason why we're here. But another important component is that because health happens at home, a lot of the dimensions that influence those actual sort of objective clinical metrics are metrics that traditionally have not been measured. So now that we have existing census metrics, and I am absolutely positive that in the world of social determinants of health, we will come up with more useful metrics that we can apply. Now we can start thinking about people in a very sort of multi-dimensional, three-dimensional, but of course even more than three-dimensional way. And as Vindell alluded to, there's a lot of literature now in the scientific publication space that show that these social determinants are often more determinative of someone's disease status than some of these even, presumably objective. Well, they're certainly objective, but not enough, right? So this is really our opportunity to fill in a lot of the gaps that we have. There's an analogy I often like to use is, astrophysicists talk about the Big Bang, and then after the Big Bang, there's a ton, most actually of the energy and the matter in the universe we actually don't account for, we can't observe. Most of health traditionally has been unobserved. So I think a responsibility of digital health platforms like Onduo is to actually start shining a light on those things. And then by shining a light on those things, can we expose the dark matter of health? And then can we actually expose or identify opportunities to help improve health in ways, again, that traditional healthcare has not usually addressed? So I think that's a really important opportunity for us. And that's where I think digital health gives us a real lever into what happens to people on a daily basis in a way that influences their health.
I love that. I'm going to steal that. The dark matter exposing health. Thank you, Erich. And for anyone who's interested in asking a question to our panel, please go ahead and submit it in the chat. We're saving time at the end for Q&A. But to kick us off in the conversation, Vindell, back to you. Your experiences have taken you from Washington, D.C. to Louisiana and now into an alphabet company. Can you share what you've learned along the way?
Sure, I'm happy. I too am determined to steal the exposing the dark matter of health analogy. I love that that Erich put on the table. Look, I'll share one of my early stories. I was privileged to serve as National Coordinator for Health IT and prior administration. And one of the exercises we did was to really look at communities. And, you know, the other thing that Erich said, like, what we've done in the past just has not been enough. So one of the observations I had there was really looking at life expectancy in certain communities. And the one that I came across there was a comparison of areas within Baltimore. So there's the area down by the harbor, which is relatively affluent, where I guess not new anymore, but where the replacement Orioles ballpark is. And then maybe west of there, where closer to Johns Hopkins, where it's a little bit of a tougher neighborhood. And I remember being struck by the fact that someone had shared that the life expectancy differences between those communities was roughly 20 years. So I left the administration. I came to work here in Louisiana, and I asked the same question about really what's going on in New Orleans East, near the Ninth Ward, sort of a neighborhood that's had a lot of stresses from the social determinants perspective, and then maybe someplace in the Garden District, a really nice neighborhood in New Orleans proper. And it turns out that it's an even greater difference in that community. So what I would say is the eye-opening piece for me, or the epiphany for me, is that those stories are not unique. They're not unique. Communities matter. And as I think about like what our role should be in this, I would say, when I say it has not been enough, traditional fee-for-service approaches in this space have simply not done enough to break down the disparities in care and to reduce the disparities in outcomes among communities that are literally within walking distance of one another. So one of our missions, one of our passions about this is to really move forward in this space and to do a flag plant around what's the right thing for those communities. I would say the other observation I would make is whether I was working with a payer or with the federal government or indirect care, I would say that most people really wanted to both live and provide care and be a part of a health ecosystem where those disparities did not exist. They wanted to be in health ecosystems where the focus was on value, where the focus was really on lifting the health status of populations. But I'll tell you, one of the barriers and one of my reasons for coming to Verily and Onduo is that there's just not enough tools, not enough good tools in the space. So knowing what happens with an individual, being able to collect the information that Alex talked about earlier, being able to sort of narrow and zero in on the right path for an individual requires a technology infrastructure that we've not had in medicine before. And so one of the other learnings is that, you know, we really have to think about what is necessary to reduce those disparities. And I think one of those areas is more insight to the individual and an ability to gather and use technology in our favor, because this sort of scaling from an N of one, what's important and necessary for an individual to an entire population, just cannot be done with the amount of manpower that exists in the ecosystem. And the last thing I would just sort of say, we carry this one mantra around the company, which I think the more I'm here, the more it resonates with me. And that mantra is that we often know what the right thing is, and that's us as providers, and that's also individuals in the community. It's rare, quite frankly, to find a diabetic that doesn't know they should pay attention to their sugars. It's rare to find a person who has hypertension that knows that they shouldn't eat a lot of salt and should take their medications. And it's awfully rare to find a patient who's gone to a care deliverer and gotten sort of wrong advice, wrong direction. Not that it doesn't happen, it's rare. So one of our goals, one of our mantras is really to make the right thing the easy thing for the individual who's put in that circumstance. And what I would say, in communities that are under stress, in communities that have the kind of challenges in the areas of social determinants that Alex laid out one by one in the last one of his last answers, we have to be prepared to do things that bend the curve and reduce the barriers for individuals who are trying to do the right thing.
I love that, bending the curve. And I knew you were going to go into making the right thing the easy thing. And it's a great segue to take it over to Erich. Developing programs to address population health requires a lot of insights. What should we be doing as an industry to foster population health strategies that account for all members of a population?
Right. If Vindell's goal is to make the right thing to do the easy thing to do, actually one of the underlying assumptions is that you actually have the information to actually make that easy. And that, you know, honestly, the easy, making that right thing to do easy to do is actually hard on the platform in terms of how you do that. And that's actually a challenge that I think all of us welcome, right? And that's a big reason why we've come to Onduo, we've come to Verily, because there is sort of that data horsepower and computational horsepower to do that. But what exactly do we actually need to do? So what I'd say is, if health happens at home, and if our job is to sort of shine a light on that dark energy, dark matter that informs people's health in a way that's usually invisible to traditional healthcare, then you need a data infrastructure that can accommodate that. Right, because when you think about conventional healthcare, we sort of, it's still a paternalistic model. We put all this information to the EHR. The EHR, for the most part, is a one-way sort of information, stream. What I'd say is we need to build a more conversational data infrastructure, one where you can have that back and forth. And in many cases, when you're dealing with the patients and you can actually have that conversation via their mobile device 365 days a year, is that there'll be times where, for that patient or member, it's too hard for me to deal with this right now. It's too hard right now. I'm so stressed I can't take my, my blood pressure medication, something like that. Well, if you're in a conversation, you can actually have that conversation later, right? You can defer. Whereas in healthcare, it's like, oh, you got to set another appointment up and who knows how many months it'll take for someone to come back in. So I would say a big part of that is building that conversational data infrastructure, which, we see works in so many other spaces other than healthcare, but for some reason in healthcare, it's been really hard. So building that conversational data infrastructure where there's a two-way data flow, not just a one-way data flow. We're going to tell you, what's going to happen to you. We take your blood and we will show your results to you through your patient portal. Let's actually make that a two-way street. And then by having that two-way street, then you can start addressing something that is sort of a big strategic mission at Verily, where we're talking about precision health as being really our strategic North Star. Now, what does precision health mean? Well, a lot of people talk about precision medicine and being able to exquisitely target interventions based on characteristics of a person. It started in cancer where it's characteristics of a tumor. So now that we're thinking about characteristics of a person and characteristics of a population, I would say another sort of alliteration to precision is presence, right? Because as I was mentioning, by being available on a as needed 365-day basis, that presence gives you the opportunity to incorporate all these signals, right? And so if using all these signals, such as social determinant information, to better tailor someone's care, well, you've got to be present in order to do that. You have to be there for the patient and in a convenient way, right? Because again, maybe they forget to mention something to the doctor when they're in the exam room on a annual visit. If you forget today, you can actually bring up the topic tomorrow if we're present there. So what that also means is that conversational infrastructure actually has to be a pretty open sort of data architecture as well, so that it can incorporate all these different signals. Traditional healthcare has a lot of trouble, frankly, dealing with social determinants data. We now do have social determinants questionnaires that we add into the electronic health record, but it's really sort of almost, there's almost an impedance mismatch between, you know, how we're used to delivering medicine via procedures and medications to how do we deal with these social determinant challenges. So I think that open architecture that allows you to incorporate that into, you know, how you think about a person is really important as well. And then by having that open architecture, then you can actually start creating the algorithms to help you winnow through that information. Is it relevant today? Is it more relevant tomorrow? Is this another way we can stratify someone's risk based on, you know, certain disease characteristics? These all add up together to sort of creating a much more rich environment in which to think about the data about people, and then a way to expose, like we've talked about, the dark matter of health. So I think that's the really sort of the implications of what we're trying to do on actual data and technology infrastructure.
Excellent. And Alex, I know you've done some work in this space. Can you tell us what we've learned, some key learnings along the way?
Sure, glad to. So let me start by saying that the work that Onduo has done in this space is driven by quality and quality improvement, especially to ensure that the quality of care is equitable across different SDOH. So Onduo does this by connecting members to the communities where they live and measuring 13 different SDOH variables of those communities across the 5 different SDOH categories that I mentioned earlier. So here's some of the things that we learned. First, around enrollment, Onduo gets a list of from their clients of members who are eligible for the program. So all of these members are employed and have insurance. So the list is already reflecting a bias against certain SDOH. Nevertheless, there are many people with employment and health insurance who do come from disadvantaged communities. And what we see is that the population that enrolls in Onduo is very similar to the population that's eligible for enrollment across different SDOH variables, including socioeconomic status. In addition, we actually see that members from the Black community and from rural communities enroll in higher proportions. So reflecting that they're having relatively improved access to healthcare through the app. Still, we did see that there are challenges enrolling members from Hispanic communities and communities with unstable housing. I will say that Onduo has recently rolled out a Spanish language version of the app, resulting now in increased enrollment from Hispanic communities. Now, once these people have enrolled, we notice at baseline that there are healthcare disparities that reflect the healthcare that they had been receiving before coming to Onduo. In particular, looking at poor glucose control, we see that this was more prevalent from people from communities with low household income, from high unemployment, and from Black and minority populations, reflecting disparities that we found also in the literature. Once they come into Onduo, we see that these people, regardless of SDOH, equally engage, you know, in the coaching and the telemedicine and glucose monitoring, all of the things that are part of Onduo. And so when we look at how well they improve their glucose control for those who have poor control at baseline, we see no difference by SDOH. In fact, when we compare against usual care benchmarks, people did equally well improving glucose across every variable of SDOH. So what we did is for every SDOH variable, we grouped our population based on how advantaged or disadvantaged they were along this continuum. And what we found is that for every single SDOH variable, both the advantage group and the disadvantage group had equally substantially improved outcomes compared with the usual care. There was no difference in impact, whether you came from a rich community or a poor community, from a minority or majority community, whether you were from a rural area or an urban area, more educated, less educated, whatever. Every group had substantially improved glucose control compared with usual care.
Thank you for the perspective on learnings. I know that with a member population of more than 56% female and enrollment being for members over 60 is actually 50% greater than individuals under 40. We do keep diversity and inclusion and health equity as a top priority. And we really drive the Onduo program through that lens of having, the inclusivity as a guiding principle. So just want to shift that, acknowledge that this is such an important piece of the conversation. And thank you. If there's anything to take away here, it's that you can't change what you don't measure. What can be measured can be improved. And as part of our whole health measurement, we believe it's important to examine social determinants of health. And in looking at some of the questions now, to shift gears a bit, questions from the audience. First up, what tools and resources do consumers need to make informed decisions on precision healthcare? And Vindell, I'll pass this one to you first.
Yeah, if I could just make one last comment on Alex's readout. I would just say we're particularly proud of the results, but I would say we're by no means complacent. So in our assessment, one of the ways that we've gotten those results is by taking each individual as an N of one. And so I would say to you, part of that approach is not every single person gets exactly the same order, sequence, or intensity of intervention. But it's that sort of customization, that sort of precision health approach that Erich talked about, which we think is really the right path to follow. So we're completely committed to sort of going further down that path. And we think that's a little bit of the secret sauce that has gotten us to what we've achieved so far, but there's clearly more work to be done. I would say in answer to the question that you raised, Natalia, about really what needs to be in the toolkit, what kind of services are required to help people be smart consumers, I would offer one framework on that. It's really hard in any practice setting to be accredited if you're not a provider who is essentially giving information and trying to make sure that folks are making informed decisions. That's sort of part of the mantra. It comes up in JCAHO surveys. It comes up in medical home surveys. There's a lot of work across the industry. But I would tell you, in my opinion, we've often fallen short. So there's a lot of literature, not necessarily health literature, but a lot of literature and education about how you help people get to the right level of understanding, particularly adult learners that you're trying to provide information to. So in my experience, when I was on the health system side, there would literally be boot camps for folks who were newly diagnosed, for example, with diabetes. So you would get your diagnosis and then they would say, guess what? Come here next Thursday. We're going to spend 4 hours with you in the morning, let you have lunch, and a little bit of a 2-hour session in the evening, and we will sort of launch you into this world of chronic disease that you may live with for the next 40 years. And everyone who's looked at that and studied that says that there are better ways that we might educate individuals. So what I'm saying is that part of that burden actually rests on the healthcare delivery system to provide information in a way that makes sense for the individual. So what does that mean? It means a lot more attention being paid to what I call just-in-time delivery of information. And so when is the right time to talk to someone about their medications or the side effects? Maybe it's when they are ready to take their medications. Maybe it's not an hour 3 of a 6-hour session of education. And what we've found is that as we sort of break down the information and the discussions with individuals into smaller packets and really at a time and place of their choosing, people do much better in terms of understanding their disease. We measure things like the diabetes distress score. Those scores get better over time if we provide information that particular way. And so I would say it is indeed a fact that people should be active consumers of healthcare. But I'd also say a fair bit of that burden rests on us as we sort of hold that responsibility in the care delivery space. And the last thing I would sort of add to that is I also think it's important for us to think about not just adult learners and how we determine and deliver information, but not every segment of the population that we serve is exactly the same. And so when we think about the ways you might approach someone who is 75 years old versus someone who is 35 years old, there may be differences. We find those differences out by asking folks. The last thing that I'm willing to accept is that someone who is in the Medicare age group is not able to participate in this digital revolution around medicine and care delivery. That's not what we've seen so far in the pandemic in terms of who accepts telemedicine visits and who engages. It's more around, are we being humble in the way that we ask questions about what people need? And then are we responding and delivering the services and information in a way that fits them in their life? And so that might mean, not just things that you can get from the Google Play Store. Maybe they're texting information delivery mechanisms we deploy, which we do as a company. Maybe it's really even down to a phone call or personal touch that helps kick people off on a service that they require to live their best life. And so we think that sort of humble approach to what members need and really taking our role and responsibility as educators in this space will really help us on those two questions.
Excellent insight, Vindell. Thank you. And we are out of time, but we will take some of these additional audience questions back for next time. I want to thank our wonderful panel. Time is up for today, but tune in next time for the next episode of Commitment to the Conversation, where we'll discuss product inclusion with Dr. Ivor Horn, Director of Health Equity and Product Inclusion at Google, Andre Blackman, the founder and Chief Executive Officer of Onboard Health, and ours truly, Dr. Vindell Washington, Chief Executive Officer of Onduo. Thanks, everyone. I wish you a wonderful rest of your week.
Thank you, Natalia.
Thank you, Natalia.